My name is Valerie Moran, and I'm a researcher at the Luxembourg Institute of Health, LIH, and the Luxembourg Institute of Socioeconomic Research, LISER. Today I'm presenting research on investigating the relationship between unmet need for healthcare and utilisation of healthcare across European countries. This research is co-authored by Professor Ellen Nolte of the London School of Hygiene and Tropical Medicine, Professor Mark Sjork of LISER, and Dr. Maria Ruiz of LIH. I would also like to acknowledge financial support from the Luxembourg National Research Fund. So access to care can be measured using survey data, and the two most common variables are unmet need for healthcare and utilisation of healthcare. And previous studies have investigated the relationship between these two variables, but only within a single country. So there is a lack of cross-country evidence on the relationship between unmet need and utilisation of healthcare at both the individual and the country level. And it is this gap that we seek to fill. We draw on the conceptual framework of Lefesque et al. 2013, and they conceptualize access in terms of supply-side dimensions of access, which include approachability, acceptability, availability and accommodation, affordability, and appropriateness. And these are complemented by demand-side determinants or abilities, including the ability to perceive, to seek, to reach, to pay, and to engage with healthcare. The methods we use are multi-level models because we have individuals within countries, and these models allow us to model the correlation between individuals within countries. So essentially they recognize that individuals within the same country will be more alike compared to individuals in other countries. Multi-level models also allow us to identify the residual variation in our outcome variables at both the individual and the country levels, and we can calculate the correlation between this residual variation in our outcome variables at both the individual and the country levels. And then we can identify different groups of countries based on this residual variation. The data we use is the European Health Interview Survey, which is available from Eurostat. We have data on individuals from 30 different European countries, and these individuals are aged 15 years and over, living in private households. It's a very rich data set, and we include characteristics covering health status, including self-reported health, chronic conditions, limitations in activity due to health, different measures of utilisation of healthcare, including utilisation of GP, specialist and inpatient care, measures of unmet need due to weight, due to distance or transportation, and due to financial affordability, health determinants, including smoking, alcohol consumption, and BMI, and socioeconomic status, including education, employment, and income. We use data from Wave 2, which covers 2013 to 2015. More recent data was collected in 2019, but that is not yet available. We also include some variables reflecting different health system resources, including the numbers of of GPs, of specialists, of curative care beds. If countries have a gatekeeping system whereby individuals must have a referral from primary care to specialist care, and also out-of-pocket spending. And the health system resource variables are sourced from the OECD and Eurostat and also the European Observatory on Health System and Policies. So now we move on to look at our different outcome variables. We start with utilisation, and here we can see GP consultations. And we can see that there is some variability across countries. In general, countries have quite high levels of GP consultations. So for example, in France, 88% of individuals reported that they had a GP consultation in the previous year. The lowest percentages are in countries like Romania and Cyprus, which is a clear outlier with only 15%. Here we can see specialist consultations, and as we would expect, there's a lot more variation across countries because, of course, in some countries, individuals must have a referral from primary care to specialist care. And so we can see that the highest percentages are in countries like Germany or Austria, where there is no gatekeeping or where perhaps there is some limited gatekeeping. And then in contrast, there are much lower percentages in countries with strong gatekeeping systems like the UK. In terms of inpatient admissions, again, some variability across countries, but in general, less than 20% of individuals report an inpatient admission over the previous year. So it's highest in Ireland with 18% and lowest in Romania with 5%. In terms of our unmet need variables, here we can see unmet need due to long waiting list. Again, a lot of variability across countries. It's highest in Luxembourg, where 32% of individuals reported an unmet need due to a long waiting list in the previous year. And it's lowest in Romania, where only 3% of individuals reported an unmet need. Other countries with relatively high percentages include Italy, Portugal, Ireland, and these are countries where waiting times have been identified as a policy issue. Here we can see unmet need due to distance or transportation. Less than 10% of individuals report this unmet need in all countries. Again, some variability, highest in Italy at 9% and lowest in Cyprus with less than 1%. So here we can see unmet need due to financial affordability and a lot of variation across countries. So over 20% in Latvia and Ireland. And in Ireland, this may be because most of the population, with the exception of low-income groups and older people, have to pay out of pocket for GP care. And then, in contrast, we have countries like the United Kingdom and Norway, where only 1% of individuals report unmet need due to financial affordability. And of course, in the UK, where care is free at the point of use, this would be expected. So here I have highlighted some results in terms of what individual characteristics are associated with the different outcome variables. So we can see that lower health status, as measured by self-reported health, if a person has a chronic condition, or if they have limitations in activities due to health, These variables are associated with both higher unmet need and higher utilisation of healthcare. Variables associated with lower unmet need and higher utilisation of GP and specialist care include having moderate and high social support and having a higher income. Daily smokers are associated with higher unmet need and lower utilisation of healthcare. And living in a less densely populated area, perhaps a rural area, is associated with higher unmet need due to distance and lower utilisation of GP and specialist care. In contrast, living in a less densely populated area is associated with lower unmet need due to weight and affordability and lower utilisation of specialist care. And then in terms of the health system characteristic variables, we only found a statistically significant association for the variable measuring gatekeeping. So the need to have a financial incentive or an obligation to have a primary care referral to specialist care. So it was statistically significantly associated with a lower probability of a specialist consultation. And again, this would be a result which we would expect. So here we can see the correlation between the residual variation in the different outcome variables. The numbers in bold are the correlations at the country level. In general, we can see that the correlations are not very high. They are mostly statistically significant at the individual level. At the country level, the relationships between the different measures of unmet need are statistically significant. And also there are statistically significant correlations between the different utilisation measures. We only find a statistically significant correlation between the measure of unmet need for weight and GP consultation, and that's around 30%. So we think this may be due to two reasons. One may be that there is GP gatekeeping. So individuals need to go to their GP to have a referral to specialist care, and then they may need to wait to see the specialist. Or there could be some substitution happening, particularly in countries where there's no gatekeeping. So there may be long waits to see specialists, and so instead individuals go to see their GP if there is a shorter wait. So here we can see the different groups of countries according to whether they have below average unmet need on each of the measures or above average utilisation. And we can see that those countries with above average GP utilisation and below average unmet need due to long waiting lists are really a mixture of countries in terms of their financing system, with both social health insurance or taxation-based systems, or their gatekeeping systems. So we have Austria, which has no gatekeeping, France, which has incentives for gatekeeping, and the United Kingdom, which has quite a strict gatekeeping system. So thank you very much for listening to this presentation. I very much welcome any comments or feedback, or indeed any questions that you may have. And please do not hesitate to contact me on either of these email addresses. Thank you.